Hello, welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. This is our first Grand Rounds presentation in 2021. I wanted to acknowledge the advisory panels that have contributed to generating ideas for individuals who can present in our Grand Round series. There's participants from our department suggesting presenters in education, clinical work, faculty, staff, trainee development, research, with contributions from trainees as well. Today's presentation is funded by the Garvey Institute. I want to acknowledge that as well. And want to remind participants to please complete the post-presentation evaluation. As I mentioned last time, it's helpful to see this, to see what participants think of the Grand Rounds presentation as we continue to adapt to this model for Grand Rounds and adjust how we're doing it. I want to talk for just a minute or so about today's presenter, Dr. Daniel Mama. Dr. Mama is an associate professor in the Department of Psychiatry at Washington University School of Medicine in St. Louis. And if I was counting correctly, and in his CV, I believe he's been at Washington University for approximately 20 years now, starting initially as a psychiatry resident, moving through a postdoctoral research scholarship program from instructor to assistant and now associate professor, and has done a lot at that institution. Several points I want to mention about Dr. Mama's biography. I guess I'll work backwards. Starting in 2020, became the director of what's called the Washington Early Recognition Center, a multidisciplinary program focusing on identifying individuals at risk for psychosis and developing treatment plans. In 2010, a notable point, Dr. Mama was the founding president of the Missouri Psychiatric Association, a founding president. Several years later, in 2014, he was recognized by the NIMH with the Biobehavioral Research Award for Innovative New Scientists. Today, we've invited Dr. Mama to discuss the diagnosis of the clinical high-risk state for psychosis and descriptions of neuroimaging studies related to that condition. I'll stop for now and have Dr. Mama begin. Thank you.
So thank you for that kind introduction. Can you all see this clearly?
Yes.
Yeah, so thanks for the introduction, and thank you to the department for inviting me to this talk, and at a great university. Unfortunately, we can only do this virtually, darn COVID. I would have loved to meet some of you in person. Also, I should say I have family in Seattle, but sadly, I've not yet had a chance to visit. I hear it's a beautiful city, so maybe next time. But I'm excited to be here today to speak about the psychosis prodrome, or clinical high-risk state. And this is an area that has been getting increasing attention in recent years. Yeah, quick disclosure slide. I don't really have any conflicts to disclose. Our studies are mainly funded by the NIH. So we are probably all familiar with the term psychosis. It's a clinical term for being out of touch with reality. Psychotic patients tend to hallucinate, hear voices, they may be paranoid or otherwise delusional. Schizophrenia is the most common psychotic disorder, and arguably the most severe. Psychotic disorders are not uncommon. It doesn't spare any demographic group, males and females, people of every race, even famous people, though they often hide this because of stigma, which is understandable. You may recognize some of the people on this slide. John Nash, for example, we may remember he's the a brilliant mathematician and star of the Beautiful Mind movie. He was diagnosed with schizophrenia. I'm also brilliant. For those of you who play chess, you may know Bobby Fischer. He was the legendary US chess player and world champion. He had some sort of psychotic disorder. We don't quite know based on availability of records, but it's been speculated that he had some kind of a psychotic disorder. He suddenly quit playing chess at his prime and became a recluse in Iceland. He spent his final years appearing disheveled, periodically making delusional statements. So somewhere around 1% of the population will have schizophrenia, maybe a little less. But the prevalence of psychotic disorders in general, which includes some of the affective psychosis, is closer to 3%. Due to the resulting disability, patients are more likely to be unemployed or homeless. They also have a shortened lifespan, at least 10 years shorter than would be expected otherwise. And this is due to the increased medical comorbidities in this population, partly due to lack of self-care. Patients also kill themselves at much higher rates than the general population. It's estimated that it's about 5% of the population of schizophrenia patients will commit suicide. This figure shows the typical course of schizophrenia across the lifespan. The onset of schizophrenia usually occurs in late adolescence or young adulthood, around the time they are starting college. Patients experience the classic psychotic break, which we may be familiar with, where relatively suddenly they begin to become delusional, bizarre, or maybe they may start to hallucinate. And the sad thing about schizophrenia is that most of those affected never quite return to baseline, even with treatment, as you can see in this figure. And this is really why the field is interested in early recognition. If we could intervene earlier, during the prodromal stage of the illness, we may be able to prevent, the irreversible change that takes place later. So this is, so one thing, we know that the earlier you intervene in psychosis, the better the long-term outcomes. And this is the result of a meta-analysis of studies looking at the so-called duration of untreated psychosis, how long someone remains untreated after the first psychotic break. In the US, the average is somewhere about a year. So about a year passes by on average before someone is treated after a first psychotic break. So that's not good. And what studies are consistently showing is that the shorter this untreated psychotic period, the better long-term outcomes are. So we're talking about social and vocational functioning many, many years later. So it is really important to start intervention early to give these young people the best chance at life. And so this is a brain imaging study of showing some of the changes that occur in psychosis. This was a longitudinal study of early onset schizophrenia. And it shows that while some degree of gray matter loss is normal, the gray matter loss in schizophrenia is exaggerated. So here it's shown in red color. Now this, oops, did I miss one? So of course the question is, can we modify this progressive brain change? This progressive brain cortical shrinkage that occurs with psychosis. And many studies have suggested that we can do that with the right treatment. So for example, this was one of our studies where we looked at a large cohort of people with first episode psychosis. Half were randomized to haloperidol an older generation antipsychotic, and the other half was treated with the typical antipsychotic olanzapine, and patients were followed for 2 years. So the figure shows a three-dimensional reconstruction of the changes in the hippocampus in the Haldol and olanzapine patients, as well as in healthy controls. And what we found was that the haloperidol treated patients showed greater shrinkage with time. So here it is shown with the blue color compared to olanzapine treatment. So such differential effects of antipsychotic on the brain has been also shown by other authors. And it kind of indicates that progressive brain changes can be moderated with treatment. And it also shows a potential role for advanced imaging methods in monitoring medication effects in the brain. So one of the underlying causes of this brain shrinkage, now there's several, one of the main causes is a loss of dendritic spines in the brain. So when you look at these when you look at brains under the microscope, you see that people with schizophrenia, they tend to show less dendritic spines. Now the spines are these little protrusions on the neuronal processes, which is where other neurons communicate with them. So it's basically their points of synaptic contact. And it also explains why the neural connections are affected in schizophrenia. So this graph shows that there is a normal process of so-called synaptic pruning that occurs in everyone, where unnecessary neuronal processes and spines are eliminated. And this occurs sometime in adolescence. And in this pruning process appears to be exaggerated in schizophrenia, and likely kind of explains why the first psychotic break occurs very soon after this process occurs. So it seems clear that intervening as early as possible would be the best thing for patients. If we can get them at the prodromal stage, even better. Now the challenge is identifying people who are prodromal. So how do we identify this psychosis prodrome? Well, the reality is we really can't, because the prodrome designation can only be made retroactively, right? Because not everyone with specific symptoms will develop schizophrenia. But what we can do is identify a clinical state that puts you at a much higher risk for developing psychosis. Over the last couple of decades, there have been some diagnostic criteria that have been proposed. And I highlight some of the main ones here. There is the so-called basic symptom criteria. It's not really used very much in the US, and it's really based on measuring specific traits like thought blocking or perseveration. The gold standard in the US and in most other countries is the so-called clinical high risk criteria. And there are three major subtypes. The most common is that characterized by attenuated degrees of psychotic experiences. These patients generally have preserved insight, but again, they have this attenuated, not quite schizophrenia-looking psychotic experience. And as you may know, the DSM-5 has also proposed the diagnosis of attenuated psychosis syndrome that was based on this research. So in addition to having milder symptoms, patients, again, they tend to have a more intact insight or reality testing than you would typically see in a psychotic disorder patient. So we often think of only psychotic symptoms during the prodrome, but in fact, there are other symptoms that tend to really be more prevalent. And psychosis really occurs later on in the development of a psychotic disorder. Negative symptoms, depression, anxiety, cognitive deficits, like decreased attention, are actually more common and tend to occur earlier. But the problem is these other symptoms are nonspecific and cannot really be used for risk prediction. So over the last 2 decades, there have been a lot of studies trying to understand these psychosis risk traits, how symptoms change over time, and what kind of predictors of schizophrenia conversion we can identify. Now, most of these have been smaller studies with low power. Now, I've highlighted some of the larger multi-center landmark studies. In the US, the most notable one is the so-called NAPLS study. And it doesn't sound like it's an American study, but it is. It's an acronym, NAPLS study. And it was conducted over 8 US and Canadian sites. Last year, the NIMH funded 2 large outcome studies, including the ProNet study, which has 26 international sites, and they're going to be looking at about 1,000 clinically high-risk patients. Our site at WashU is one of these sites. Subjects will be followed over 2 years, and a range of biomarkers, MRI, EEG, blood work, behavioral assessments will be conducted. And let me just talk a little bit about the NAPLS study, which has been the largest longitudinal study of clinically high-risk youth prior to the recent ProNet. The goal of NAPLS was to identify traits that predict who will progress to a full-blown psychotic disorder like schizophrenia. And what they found was that roughly 1/3 of people with this clinically high-risk diagnosis ended up with a psychotic disorder after 2.5 years, right? So the majority of people that have these clinically high-risk criteria, that met these clinically high-risk criteria, never ended up having a psychotic disorder. They would just have persistent, attenuated symptoms, as you can see in the graph that I just put up. Or as in the green line, shows, psychotic symptoms actually resolve in some patients that initially have attenuated symptoms. They also found that there were some clinical characteristics that are more likely to predict psychosis conversion. For example, those with bizarre thoughts or disorganized behaviors were more likely to develop schizophrenia. NAPLS also looked at brain predictors of psychosis conversion. This is one notable study from that project. What they found here is that among those who converted to psychosis, there was a greater rate of gray matter loss in specific regions of the frontal cortex, right? So specifically in those people that converted and not in those that didn't. So such studies show promise that maybe in the future, perhaps we may be able to use the tool of neuroimaging to determine who will have schizophrenia and who to treat more aggressively in the prodromal stage. So research on the clinically high-risk state and first episode of schizophrenia has in recent years led to the establishment of several early psychosis treatment centers around the country, specializing in this population. The red dot here is our center. And this time we are the only center in Missouri. And this is our center. It's called, the acronym is WERC. It is new. It was launched early 2020. We have about 55 patients that are currently registered in the clinic. These include clinically at-risk populations, as well as those that are at an early stage of a psychotic disorder like schizophrenia. And generally what these early psychosis clinics aim to do is to use evidence-based treatment approaches to provide the best care for early psychosis patients. Now, of course, the field is still evolving, and there is a lot that we still have to learn about treating this population. This slide gives a simplistic overview of the interventions that have been found useful at different stages of life. Family psychoeducation and supports and CBT, cognitive behavioral therapy, have been shown to improve outcomes in higher risk individuals, especially. In teenagers, preventing drug use is very important. And I think it's important to emphasize this. In particular, marijuana use is associated with increased risk of developing psychosis. Doesn't appear to be the other drugs, cocaine, heroin, but marijuana. It seems to be something about marijuana. I think the reason that that's really important in psychiatry is I think we probably have to be more aggressive in discouraging cannabis use in this vulnerable stage of development. It's probably fine after your late 20s, but in adolescents, people in the early 20s, especially people who may be at risk for schizophrenia, cannabis probably should be discouraged. Early psychosis work is also going on internationally in most regions of the world. Countries are realizing the value of identifying populations early and intervening earlier than later. And some of our earliest work in psychosis was actually done in Kenya. I was hoping to talk a little bit about that. We are currently the only group in Africa who is studying early psychosis and the psychosis-risk populations in the continent. And now some of our initial studies looked at measuring the prevalence of psychotic experiences in high school and college students. Here we used a WHO screening tool to screen for a history of 6 different psychotic symptoms. Now we found that about 22% of the people that we screened endorsed having had some psychotic experience in the past. We also did a latent class analysis where we showed that there were 2 classes of people endorsing psychotic symptoms. There were those who had mainly auditory or visual hallucinations, and those who had more of a mix of psychotic experiences, including prominent delusions. So we call these type 1 and type 2 psychosis. So type 1 is the more hallucinatory, and then type 2 is the more mixed hallucinations and delusions kind of psychosis. Now, that potential relevance of this is that the type 2 psychotic folks are more severely affected in general, also functionally, and are more likely to develop schizophrenia. So maybe there's some role in treating this population differently, maybe monitoring them more or treating earlier. One thing that we noticed in the course of our studies is that there really aren't great questionnaires for measuring psychosis symptom severity, at least when we started our studies. And then many of them didn't really seem to be cross-culturally applicable, right? They may be applicable in the US, but not so much in Kenya or Africa, for example, based on cultural differences. So we developed one of our own. We call this the WERCAP Screen. The WERCAP Screen estimates psychosis symptom severity using frequency of occurrence and functionality ratings. And again, the main goal of developing this screener was to identify those who are at a clinically high risk for psychosis, and has since been validated using structured interviews. There's also a part of the screener that tries to look at risk for bipolar disorder, but I'm not really gonna go into that too much today. We have since developed some additional questionnaires, those measuring stress severity or substance use. Again, these are very easy to administer questionnaires. It usually takes about a minute or less to complete, so it's very practical. If anyone is interested, you can download it for free on our website. We found it very useful. One of our more notable studies in Kenya was actually funded by the NIH. This was a longitudinal study, almost 2 years. We identified about 300 people for the study. We screened about 3,000 or so using the WERCAP screen. And these are some of our results. We found cross-sectionally that psychosis risk youth tended to be more comorbid for other psychiatric disorders, as you can see here. They also report higher degrees of stress than controls, and greater impairment in some cognitive domains like attention and verbal memory. Interestingly, some other cognitive domains like emotional differentiation or abstraction were not impaired, or maybe even a little bit better in the psychosis risk youth. So that would have to be replicated. But there were clear differences between the high risk youth and healthy controls. And we also, so what our longitudinal analyses found was that only 4% of these high risk youth progressed to a psychotic disorder at the end of the almost 2 years. This was much lower than in US samples. If you remember, in the US, it tends to be about 20–30% over a little bit longer time period. So what we found was a little bit lower conversion rate. Now, one reason for this may be the duration of the study. So ours was about 20 months, and that compares to the US studies, which were closer to 30 months. So it may just be that we haven't, the patient just hadn't had enough time to convert. Another reason may be that our subjects were roughly 2 years younger than those in the US NAPLS study. So that suggests that perhaps many of them might have been too young to convert to a psychotic disorder within that time frame. Now, similar to NAPLS, we found disorganized communication as a predictor of conversion. We didn't find any other predictors. Again, that could be because we just hadn't had enough people converting. But it was interesting that we did find at least this one trait that overlapped with what they found in the US. And that may have clinical relevance in the future. So we have recently received an R21 grant to pioneer brain imaging research in Kenya, and actually have a larger grant under review, kind of knock on wood on that one. Again, we're going to be looking at the psychosis risk population. As you may know, there are several brain imaging methods which have been used to study the brain in psychosis. Structural methods that look at brain size and shape, or techniques assessing the connectivity of different brain regions, or PET studies, which allow us to look at brain physiology using radioactive tracers. So there have been several studies in the clinically high-risk populations. And as is the case with other disorders, there is a large amount of variability across studies. Structural imaging studies have found some of the same regions to be smaller in the high-risk groups as in schizophrenia. So the hippocampus, the prefrontal cortex, or the cingulate gyrus, for example. And as I showed in an earlier slide, increased cortical thinning in specific regions have been associated with increased risk of transitioning to a psychotic disorder. Interestingly, the hippocampus, which is often implicated in the pathophysiology of schizophrenia, has not been found to predict transition. There have been fewer diffusion studies in the high-risk groups, but generally the ones that have been published do show reductions in white matter integrity or fractional anisotropy. Now, subcortical structures have not typically been found to be abnormal in the high-risk populations. And one reason may be that existing methods are not sensitive enough to pick up some of these more subtle structural abnormalities. Non-conventional methods like the one that I'm showing now may help overcome some of this. Now, this is an example of one of our earlier brain imaging studies in early stage schizophrenia and in their unaffected siblings who have a genetic risk for psychosis. And we looked at the basal ganglia and the thalamus. Now, these are structures in the middle of the brain known to modulate motor as well as cognitive functions. And we used a computerized method to look at the shape of these structures. And what we found was that specific regions of these structures were shrunken, shown in blue and purple. But more importantly, these regional abnormalities were also present in some of the same locations in those in the siblings who have an increased genetic risk, although to a milder degree. So studies like this, again, suggest that we may be able to, in the future, identify those who will transition even at an earlier stage of development. Functional connectivity imaging, you may all be familiar with this method. It looks at regions of the brain that are working together in some kind of way or functionally. Now there have been several studies, again, with variable results, so it's very hard to find one finding. This is a notable study by Alan and Tisovich from Yale and colleagues. They looked at the functional connectivity of the thalamus with different cortical regions. And they found that in the clinically high-risk subjects who transitioned to psychosis, there was decreased functional connectivity between the thalamus and specific cortical regions, the right lateral prefrontal cortex, cerebellum, and anterior cingulate. And there was also increased connectivity with sensory motor cortex. So again, this is another evidence that there are notable promising brain imaging findings in clinical high-risk subjects that may help us predict who is going to transition in the future. Another way that we are looking at functional connectivity data is by focusing on characteristics of so-called functional networks. The brain has several of these functional connectivity networks denoted here by different colors. For example, the red here is the default mode network and so on. And the exact shape and size of these networks tend to vary from person to person. So we did a preliminary study looking at these different functional networks in people with schizophrenia. And what we found here was that the auditory network is larger in people with schizophrenia. For example, we also found a smaller salience network. Again, these subjects, I mean, these results are somewhat preliminary, but again, it's kind of interesting to speculate what this could mean. A larger, auditory network in patients may have something to do with, why they hear voices, for example. There have also been PET studies done. Again, PET uses radioactive tracers to measure physiological activities in the brain. An exciting finding has been looking at microglial activity in the brain. Now, microglia are immune cells in the brain, which are involved in synaptic modulation and pruning. Immunological dysfunction has been, as you may know, increasingly recognized as underlying schizophrenia. So this is particularly relevant. This study looked at microglial activity in the brain based on levels of a microglial protein. And they found that schizophrenia patients had the highest microglial activity. But psychosis-risk patients also tended to have higher. So their microglial activity was between that of a healthy control and schizophrenia patients. So this suggests that elevated microglial activity may be a biomarker of psychosis risk. Just real quick, GEPCI is one of the more novel MRI-based methods that were developed here in WashU, which is essentially a quantitative relaxometry. It looks at the relaxation properties of the brain. It's an MRI-based method. And based on these relaxation properties, it can determine differences in the kinds of tissue damage going on in the brain. So here we looked at the brains of those with schizophrenia and those at genetic risk for schizophrenia, as well as bipolar patients. And what we found was that the relaxation component, which suggested neurodegeneration, was the greatest in schizophrenia patients, depicted by the red line here. Now, there were some neurodegeneration signals in the high-risk folks also, but only in certain regions, like parts of the temporal cortex. Now, schizophrenia and the high-risk patients also had elevated levels of the relaxation component, suggesting increased blood flow in multiple cortical areas, here denoted by yellow. Now, some of these findings still have to be replicated, but still it shows promise that using some of these newer methods, we may gain even more insight into what is going on in the brain with psychosis. One of the big issues with neuroimaging is that there is, as I mentioned earlier, a lot of variability in findings across studies. Now, some of this may be because there are actually different etiologies that could result in similar clinical presentations of psychosis. So this is sort of analogous to the case of, let's say, chest pain and dyspnea depicted here. If somebody has chest pain or dyspnea, there could be a variety of underlying causes of these symptoms. So you'll never be successful in identifying one imaging finding that explains every single case of chest pain. Instead, we may gain more insight into etiology by trying to identify different independent imaging abnormalities that may be associated with chest pain, instead of averaging the imaging findings, which is what we tend to do. So here is an example of this concept in psychosis. We looked at white matter in schizophrenia. We found some white matter regions using diffusion imaging based on average results. So we averaged the schizophrenia patients, we averaged the controls, we kind of found some finding. But then we also did a cluster analysis of these white matter tracts based on some processing of the imaging scans. And the goal was to try to identify these unique imaging subtypes that may be occurring in schizophrenia. And what we found was that there are 5 different patterns of connectivity abnormalities in schizophrenia. So not every single schizophrenia patient has the same exact abnormality. So what is the relevance of this? Well, one possible relevance is that we may find that each unique pattern of brain abnormality may be responsive to different treatments, right? They may be associated with a different kind of etiology and may respond to something different. And so that could allow for more personalized kinds of treatment approaches. This is another imaging subtype study, which found 2 distinct patterns of gray matter abnormalities across schizophrenia patients. They also linked the different abnormalities to specific clinical symptoms. So, So what are the potential ways we could incorporate brain imaging into clinical care? Because I think ultimately that is what we would like to do. Now, first of all, I think studies would have to guide us in identifying the brain metrics that are the most relevant in identifying schizophrenia. Possibly by combining the most relevant brain imaging data, maybe by machine learning methods. Then, much like we do with childhood growth curves, we may be able to track these brain imaging metrics in those with high risk, so in high risk individuals over time. And if they begin to look more like more schizophrenia-like, we would then be more concerned and perhaps treat more aggressively. Otherwise, we may treat conservatively. So this hypothetical scenario is illustrated here. So imagine if we had 3 different patients with similar attenuated psychotic symptoms. They do not have schizophrenia, but look like there could be prodromal. So we do a brain scan, we find that only patient C has schizophrenia-like brain abnormalities. Now, in this case, we would start an antipsychotic for patient C. Oops, maybe I didn't get this correct. Okay. But not in the other 2 patients who we would continue to monitor. Maybe we would treat them more conservatively using psychotherapy. Now, if we follow patient A and B and find that patient A's brain metrics remain the same over time, while patient B is gradually becoming more schizophrenia looking, we would then medicate patient B. And hopefully we would normalize the brain changes after medication. So this is hypothetical, but again, it sort of creates some visualization of how this could be applied in the future. So I just wanted to kind of leave you with some key points. I know there was a lot here, But I think that the most important things to remember are that early recognition and treatment of psychosis leads to better long-term outcomes many years later. And institutions may benefit from having early psychosis centers. I think it's a really good addition to any kind of program to have a specialty program for early psychosis. So I think I would definitely encourage that. It is also important to know that the clinical high-risk states, mainly involving attenuated levels of psychotic symptoms, often associated with mood symptoms, anxiety, and functional impairment. Only about 20 to 30% of people with these symptoms convert to psychosis. Most of the people with these symptoms do not. They either remain attenuated or they actually get better. And that, of course, there's hope with the ongoing research in the ongoing prodromal research. Clinical features and biomarkers may improve prediction and additional roles in clinical management. So I wanted to acknowledge some of my colleagues over the years. This is not all inclusive, but many of the people I've worked with within the US as well as in Kenya. All right, and I will leave it there. Thank you. So open to any questions.
Thank you, Dr. Mama.
Yeah.
As individuals write questions in, I want to make a comment about what an inspiring blend of epidemiology, of neuroscience, and clinical services blended together, and how you've moved your research findings into the clinic, developed clinical tools that you use in research studies. It's an inspiring example. Thank you for presenting this.
Yeah, thank you.
Several questions are coming in.
Okay.
So I want to be sure to get to participants' questions. One is what about tools or instruments that could be used to screen or assess risk in children, not just in adolescents? Is that something that's done? Will you comment on that?
Yeah, I mean, I'm not really familiar with good tools in children. I think children are really complicated to test because some of these questions kind of probe kind of more sophisticated questions. And so it's been really tricky, at least in our experience. We have used our screening tool, and some of the general screening tools have been used in younger populations. I just worry about the validity in that population. So I guess the short answer is I would probably use the general tools. There may be some specifically formatted for children. I'm not aware of them yet, though.
Thank you. A question came in about comparing medication versus psychotherapy treatment for the patient and family members. With one person saying the haloperidol data seem to show reduction in gray matter. Can you comment on the importance of medications for a reduction of onset of severe disease? Do medications decrease severity of symptoms, reduce risk of classification as a diagnosis of schizophrenia, decrease severity, shorten or lengthen time until onset?
Yes, I mean, I think the short answer is treatment does appear to decrease all those things. So it does appear to improve long-term outcomes. It does appear to reduce conversion rates. But there are other studies that don't quite show that same clarity. So I think that the larger question is whether or not medications are the right treatment. So if somebody comes in with a prodromal looking symptom, if someone comes in with, attenuating, begin to hear voices, but not quite schizophrenia, do we give them haloperidol or olanzapine? I think the general consensus is no. I think that it is kind of hard for psychiatrists to do that because, once they hear, someone hearing voices, they automatically want to give a medication. But the conventional wisdom among prodromal researchers is probably it's better to wait. And part of the reason is kind of what I presented. The majority of these people will never become schizophrenic. They would never have a psychotic disorder, right? Only about 20 to 30% do. So if we're throwing an antipsychotic on every time, the risk may outweigh the benefits. So I think that a more pragmatic and wise approach would be, to follow the individual, right, over time, monitor closer, see if these symptoms are changing. Are they getting worse? Are they affecting the everyday function of the individual? And if it's looking like things are gradually progressing, then that would be a good time to start a medication. But initially, I probably wouldn't use antipsychotics. Consider antidepressants, anti-anxiety medications, maybe psychotherapy, but I wouldn't jump on throwing an antipsychotic too early.
A related question about dosing. If you're at a clinical circumstance like that, where you've decided as a clinician to start antipsychotic treatments, perhaps a clinician would proceed with low dose to start with. How might that, even low or moderate doses, sort of affect an adolescent's life? Might it reduce frequency of psychotic symptoms? Might it change functioning in some way? What about bothersome effects?
Yeah, I'm not sure there's a clear dose-related relationship. Not everybody is going to need a high dose. Some people do quite well with lower doses. Obviously, if you're going to use an antipsychotic, I would definitely urge you to use the lowest possible dose in this population. Again, because of the risks. We do know that if you keep people on medications for many, many, many years, the side effects kind of ramp up. So yeah, if you're going to use it, use a low dose. Probably should be using an atypical antipsychotic, Abilify, Seroquel, maybe some of those kinds of things, those kinds of medications. But again, I would be cautious on, rushing into treating with antipsychotics. I think it's really important to try to fight that urge. It kind of hits me sometimes too, to want to medicate right away. But again, sometimes the wisest approach is to follow and then kind of see what happens.
Yeah. I may not have a deep enough understanding of this question to add much to it, so I'll just kind of read it. Is there any correlation that shows up between imaging studies and brainstem auditory responses on psychological testing in childhood throughout early adulthood?
Yeah, I probably would say that I'm not sure. That's not really my area, so yeah.
Okay. Oh, and from Dr. Collins, I was wondering about duration of untreated psychosis as well. Can you talk a bit about the duration of untreated psychosis? Do we have an understanding of what exposure is most damaging for future prognosis during that period? For example, do we understand if elevated microglial activity or neural degeneration is the most important exposure?
So most important exposure. Yeah, we still don't quite know exactly what causes schizophrenia in every single patient. Some of those things are part of what is going on in the brain. What starts the process, we don't quite know. Like I mentioned, we do think that there is, increased synaptic pruning, abnormally increased for some reason. So it could just be that there's just a lot of synaptic pruning, which is going to involve microglial activity during that untreated period. And so the longer you don't treat, the longer that abnormal pruning can take place. And that may affect people negatively. But there's also just neurodegeneration that occurs. So it's not quite clear. And the other thing too is, it's probably going to differ from person to person. I really don't think that every person with schizophrenia has the same kind of etiology. So it's kind of hard to kind of give a generalized answer, but that's the way I would think about it.
And for clarity of a point, treatment doesn't necessarily mean antipsychotic treatment. Is that right?
I think that's a key point, right? So sometimes treatment is just therapy, is psychoeducation, is being supportive. If they're going through some kind of stressor, that's important. Another important treatment is, and I think I mentioned this previously, is discouraging drug use. I mean, I cannot overestimate. I mean, it's such an important point, especially cannabis. If you have a patient, and I can't tell you how many of our patients use a lot of cannabis, and a lot, so many of them would say that my symptoms started soon after I started using a lot. There's something that does. So I think we have to also think about that, is how can we kind of discourage these bad habits? How can we reduce stress? How can we discourage drug use? And psychotherapy, antidepressants, anti-anxiety medications. I think we have to also think about those also.
And Dr. Mama, is an individual in an early psychosis program, for example, getting psychotherapy or working with a case manager, even getting antidepressant, is that person considered to be out of the untreated psychosis window? Is that person considered in a treatment window now?
You mean if they're not taking medication?
Yes, but they're connected to a clinic, having observation, being monitored, and so
No. So if they're not medicated, typically they are not untreated. So I'm making a difference between people that are clinically high risk, so people that are putatively prodromal, right? So those are the people that I wouldn't treat with medications. Yeah. If you already meet criteria for schizophrenia or a psychotic disorder, then in almost every case, you actually need to be on an antipsychotic. So that's a different scenario. So the duration of untreated psychosis is the period after the first psychotic break happens, right? So they already meet criteria for a psychotic disorder.
Thank you. Yeah. Any comments or thoughts on epigenetic studies that might be related to microglial activity?
Yeah, I don't really have a lot of knowledge of that area. I know that genetics has a really big role in trying to understand what happens in the brain. Epigenetics, I don't have that much knowledge of.
Well, we've had a chance to go through all of the questions that were typed in by participants.
Okay.
I guess more of a practical question for your clinical service. How do patients come to your service? Is it from your university? Is it statewide? Particularly with telehealth now, how do people come to you, and where do you reach?
Yeah, we have a limited demographic area that we actually get patients from. But if you are in the St. Louis, larger St. Louis, greater St. Louis area, or Eastern Illinois, I should say East St. Louis, then you can come to our clinic. Typically, people are either referred by hospitals, clinics, pediatricians, sometimes by school counselors. Sometimes people actually just find our information online. So there are all kinds of ways that people kind of get to us. And then we kind of do a screening call, and this sort of seem to meet criteria, would call them in and sort of do a more detailed evaluation. So.
Oh, a question came in about that. What is the wait time like?
To come into our clinic?
Mm-hmm. Yes.
It's been pretty good. I mean, again, we have different phases. So the first phase is coming in to do like a more general structured interview where a social worker goes through a bunch of structured assessments, questionnaires that usually takes a few hours. To get into that stage usually takes about a week or two. So we're pretty fast. Now, that's only one stage of the evaluation. Then they would have to see a psychiatrist. The wait time there is a little bit longer, but generally it tends to be, a couple of weeks or so, 2 to 3 weeks. So far it's been pretty good. Again, that could change, but so far we've been
particularly for the adolescent age range, it's often a much longer wait. That's notable.
Yeah.
Well, we're at 1 o'clock Pacific time now, and Dr. Mama, thank you very much for joining our Grand Round series and for presenting today, sharing updates, and discussing potential next steps in your research as well. Thank you.
Thank you so much, and thank you for the opportunity.
Okay.
All right,
Take
take
care.
care. Bye.
Bye.